population with diabetes, they are not able to tolerate this particular drug, even though it is supposed to be the first line of management after lifestyle modification in diabetes. So a lot of gastrointestinal side effects can happen. Not only that, there are newer drugs like DPP-4 inhibitors and other drugs which can definitely produce gastroparesis. It can reduce the gastric outlet, emptying of the gastric content. And in this situation, if the patient is already having GERD, then we may have to switch over to some other drug. As a diabetologist, I think I can add these 2 points. Now, one of the senior reputed orthopedician of Madurai, Dr. Shanmuganathan, is being requested to give you an idea about what are all the musculoskeletal disorders which the diabetic patient can develop as a complication. We all know that most of the complications of diabetes affects only the nephropathy, retinopathy, neuropathy and all. But the musculoskeletal system is also involved in the form of osteoarthrosis and periarthritis shoulder. These things are also to be taken care of, and these are all the situations in which we refer them to our orthopedic colleagues. Now, over to you, sir. Dr. Shanmuganathan will give you a rough idea about what are all the conditions of diabetes which can produce problems in the musculoskeletal system.
Commonly, we see the very commonest condition in diabetic patients is first is periarthritis shoulder, the frozen shoulder. Most of the patients, sometimes they came to us without diagnosing as a diabetes itself. When we routinely check the blood sugar, it shows high blood sugar, and then we find it out that this patient is a diabetic patient. Such is a very common condition where we have restriction of movements and they have severe pain during night and they come to the orthopedic surgeons. So the first foremost thing is to control diabetes. They say that I have seen that doctor, this doctor like that. But the most common thing for reducing the pain in periarthritic shoulder is to control diabetes. Without controlling diabetes, no analgesics, no NSAIDs is going to act, no physiotherapy is going to act. So first, control of diabetes is very important, followed by NSAIDs. Sometimes we give intra-articular injections also to relieve the pain. And next common to that, in diabetes, we have the osteoarthritis. It's one of the major common conditions where we see in our day-to-day practice. Those patients with diabetic, it is very difficult to control the diabetic, the osteoarthritis management. Because the drugs, we are very difficult to use NSAID for a longer time. They have their own complications. And also, because of their diabetes, they have some muscle wasting, muscle weakness, and it's very difficult to treat a patient with diabetes. So we have to control diabetes, and then we have to give physiotherapy and other things. And occasionally, we used to give intra-articular steroids after controlling of diabetes. And it is found that after intra-articular injection in a diabetic patient, frequent blood sugar monitoring is essential. Sometimes we are seeing after intra-articular injection in diabetic patients, the blood sugar goes to 500 or so like that. So we have to be very cautious in treating a diabetic patient with osteoarthritis, especially when you give intra-articular steroids. And also NSAID, all complications associated GA and also CV complications occur with edema and other things. The other thing will be the back pain, the very commonest one. Most of the patients who come to us with back pain, they are diabetics or hypertensive and mainly post-menopausal osteoporosis. It's one of the major causes for these diabetic patients who was prone to develop osteoporosis. These patients, we have to be treated accordingly with analgesics and then to correct the osteoporosis.
Well said, sir. As Professor Shanmuganathan was saying, in any diabetic complications, the strict control of blood sugar, the euglycemia, is a very pivotal point. Only after that, we may be able to prevent or at least reduce the effects of complications. Thank you very much, sir. Now again, I am going to request Dr. Arun to say a few words about the use of proton pump inhibitors. And many a time, the usage of this particular drug increase the risk of acute interstitial nephritis. There have been articles which are coming up in the recent journals about reversible or sometimes irreversible interstitial nephritis, which is being noted by the nephrologist in patients who have been prescribed proton pump inhibitors. Many a time they take it for say 1 month or 2 months, and then inadvertently they continue the drug for a longer period, and this situation has to be curtailed. Recently, we had 2 or 3 lectures at Madurai where Professor Moses was also addressing it. Dr. Sampath Kumar, nephrologist, was also mentioning about the ill effects of indiscriminate prescriptions of proton pump inhibitors. All the thresholds are being to be looked after, and it has to be given only for that particular period, because proton pump inhibitors also can produce a lot of other problems like gastrointestinal infection, because it is going to produce almost achlorhydria, and this acid is important for the prevention of bacteria growing in the intestines. And elderly people, when they are given this for a longer period, they do develop community-acquired pneumonia. These are the complications which we face. Over to you, sir. You have, I think, to say something about the indiscriminate use of PPI in patients who are going to develop these problems, especially in a diabetic.
As rightly mentioned by you, it is clearly there is an indiscriminate use of proton pump inhibitors in the current scenario, especially when patients are taking multiple drugs. We invariably, including me, sometimes we invariably include a proton pump inhibitor in diabetic patients, in cardiac patients, or in neurological patients. So when they are given a certain number of drugs, we are compelled to think that adding a proton pump inhibitor is mandatory, but it is not so. Not so. Even with cardiac drugs, it's not mandatory that we add a proton pump inhibitor. That is first thing. And as we have seen in the previous slide, it was shown that both acute interstitial nephritis as well as chronic kidney disease can occur with proton pump inhibitor. Acute interstitial nephritis has been shown to occur even with usage for a month or even less, even at 2 weeks duration also. There has been case reports of acute interstitial nephritis requiring hemodialysis or even leading on to CKD. So this is the effect that we are seeing right now. And there are multiple studies. One study which I would like to mention is a huge cohort, 10,000 cohort study. It's ARIC study, atherosclerosis risk in community. There is a cohort which was used to study multiple parameters. And this ARIC study, the one thing that they studied is this long-term use of proton pump inhibitors and the risk of developing chronic kidney disease, and also the incidence of acute kidney injury or acute interstitial nephritis. So over a period of time, 14 years, they have conducted this study, and what they have, the number of patients included was more than 10,000. And what they have found was the incidence of CKD was 1.5 times more in patients using proton pump inhibitors, and the incidence of acute interstitial nephritis was 1.75 times higher compared to the general population. So it was, both were significantly different from the control population and the patients who are taking proton pump inhibitors. So this was the one landmark study which clearly stated that long-term proton pump inhibitor is associated with chronic kidney disease as well as acute interstitial nephritis. So having said and having clearly read all these things, we should be very cautious in prescribing long-term PPI. And we are now seeing many people who are almost addicted to proton pump inhibitors. Once they are started with high-dose proton pump inhibitors, they are never able to leave it. So we should restrict our prescription to days or at the maximum weeks, and then taper and stop it. And what they have also seen is twice daily PPI usage was associated with significantly higher incidence of kidney disease compared to once daily PPI usage. Sometimes we indiscriminately use twice daily PPIs. So most of the PPI we are having half-life and action for about 24 hours. So none of the PPIs currently we are having need a twice daily dosage maybe for 1 day or 2 days we can give, and then we should give at least OD dosage, and that will be for a very short period of time. And there are different mechanisms that are postulated for this chronic kidney disease development, like hypomagnesemia leading on to this chronic kidney disease and many pathologies. But the association is well established now, so we should be very cautious about this thing. And there are many doctors are also taking long-term PPI, even sometimes without knowing and with knowing they are taking. So we should be very cautious about it.
Yes.
We orthopedic surgeons, we right and left NSAIDs with PPIs.
Yeah.
So, what is the ideal PPI can be prescribed for a shorter time?
Ideally, sir, we need not prescribe PPI routinely even with NSAIDs or with antiplatelet drugs. None of the guidelines say that we should routinely prescribe PPI with either NSAIDs or antiplatelet drugs. But if the patients, only when the patients start developing symptoms, or sometimes the patient himself that insists that we have already developed symptoms, so please prescribe proton pump inhibitors. So at that time, we can use either a short-acting drug like rabeprazole. Compared to pantoprazole and esomeprazole, the duration of action of rabeprazole is shorter, and so the acid suppression is not that much complete compared to the other drugs. So we can use a shorter drug which has shorter duration of action, and also we can use for a shorter period. So once they stop the NSAIDs, we should ask them to stop the PPIs also. But routine prescription is not required in a sense.
So, before I ask our orthopedic colleague, let me ask you a question which is related to the same topic. The use of proton pump inhibitor for a longer period definitely produces GERD, and sometimes it can worsen the problem. Many a time, the GERD patients improve very well with the small courses of antacids or proton pump inhibitors. But when it is given, especially when they take inadvertently for a longer period, they do develop a lot of problem in the esophagus. It may even go up to Barrett's esophagus. And to curtail that, what exactly you can do that? To prevent the people taking PPI inadvertently for a prolonged period, are we going to do anything for that?
Usually it becomes difficult when the patients themselves try to get it over the counter and they start continuing it without our prescriptions also. But what I try to do is to switch over to H2 blockers over a period of time. When we start with PPI with prokinetic, and then we taper to only proton pump inhibitor, and then we try to switch over to a H2 blocker, and we include an antacid at the time of switchover so that they will not be having that much symptoms during the time of switchover. Because many people will not be happy with the H2 blockers when we switch over from proton pump inhibitor. So I tend to include an antacid, a short course of antacid during the time. So practically these things are necessary when we try to switch over them to H2 blockers. Sometimes we fail, and we give another short course of proton pump inhibitors. Again, we keep on trying. We should try to educate them on the first hand that taking this drug long term will lead to certain side effects. Then they themselves will have the mentality to switch over. Otherwise, they will be very comfortable with proton pump inhibitor with an prokinetic agent, and they will never stop using it. They will get it over the counter. So we should educate the patients regarding the side effects.
Basically, the patient education is important. That's correct. And a question which is related to the current topic: how often you use misoprostol in cases of gastritis or maybe drug-induced gastritis? Is it available? What is the dosage? Are you still using it?
It is not very
freely available. Yes.
Not freely available, and we are not using it currently. It is used mainly for NSAID associated gastritis because of the mechanism of action. Theoretically, it is very useful drug, but practically when we use proton pump inhibitors, it is far superior to misoprostol. So this is not very commonly available also, and also not commonly used nowadays. So we are using mostly proton pump inhibitors because of the efficacy issues.
Dr. Shanmugadan was making a mention about the intra-articular steroid injection. We were all under the impression that small doses of steroid which is put into the joint, we thought it is not going to raise the blood sugar to an enormous level. But contrary to the popular belief, Sir has told you that it can increase the blood sugar even up to 500 milligram. Sir, the question is, what are the complications of intra-articular steroids and how long you are going to give it, how often you are going to repeat it, what is the maximum duration of NSAIDs which is being prescribed?
Normally, intra-articular steroids reserved for those patients who cannot tolerate NSAIDs one, and those patients who have tried all the modalities of treatment like physiotherapy, analgesics, NSAIDs, all the drugs have been tried. Failed cases we used to give intra-articular injection. It should be done under aseptic precautions, very, very important, otherwise you are going to land up with septic arthritis. So that's the foremost thing. And then you confirm that the patient is not a diabetic, or occasionally in diabetic patients, occasionally only we use intra-articular injection in diabetic patients because of the complications leading on to thing. And also this intra-articular steroid should be used very cautiously once in a year or something like that. Not sometimes we are seeing patients having intra-articular injections every week like that. It should be condemned. So it can be given, if the patient fails your other modalities of treatment, it can be tried once or twice. So with the interval of minimum 6 months, not less than that. Because the main side effect is, one is infection, next one is damage of the cartilage. So these steroids will cause degradation of the articular cartilage. It will worsen the osteoarthritis or any inflammatory pathology leading on to severe degeneration of the joint. So it should be avoided and occasionally should be used with caution.
If not NSAIDs, is there any other modality which can be prescribed for osteoarthritis? Because many a time they come to us with severe pain and instantaneously the pain gets reduced once you give an intra-articular steroid. But unfortunately in a diabetic, the blood sugar is soaring high, we have to switch over to some other drugs. Do you have any other options, sir?
Now we have the latest one is visco supplementation. It increasing the lubrication of the joint. It's called the hyaluronic acid, which comes in high molecular weights, and various forms are available, which has to be given weekly once for 5 injections like that. Or we have the latest one with the higher molecular weight, which can be given a single injection intra-articularly. These injections are very useful only in early stage of osteoarthritis, not in severe, that is mild, moderate, severe. Severe is not going to help at all. In mild and moderate, these injections, if you give, it will be useful for at least 1 or 2 years or 6 months like that. The results are not very gratifying in all the patients, because one thing is very expensive. This injection costs 12,000 rupees, and if you give an injection intra-articular, the patient claims it should be pain-free for year long. It's not like that. So it's be very specific, and it has been given. This visco supplementation is tried only in few cases, and overall satisfaction is not very good. Overall satisfaction is not good personally, and also literature-wise. It's not very much useful for giving a visco supplementation.
So there are alternatives available if NSAID is contraindicated. Osteoporosis is a very common problem. We do come across because of so many reasons. Our women folk, they don't do much exercise at an early age group, and if they can do physical exercise, their bone strength increases, and in the later life around 40s and 50s, they will not develop severe osteoporosis. Many a time, they become sedentary life, and invariably they develop osteoporosis. Many a time, most of the drugs which are being prescribed for diabetes also can cause osteoporosis. Sir, what are the method of treating osteoporosis, and how often you prescribe vitamin D3? And if at all you prescribe vitamin D3, what is the dosage? You want to give a small doses of 1000 or 2000 international units every day, or are you going to prefer 60,000 international units every week, or very rarely you can give even 5 lakhs units as intramuscular injection once in a year? These options are available. It's over to you, sir.
Nowadays, vitamin D deficiency is prevalent worldwide, and also it is very, very common in doctors. Because if we see in this group, almost 80% will have a low vitamin D3 level. It is so because we are not exposed to the sunlight. We use in a AC car, we sit in the clinic, no activities. So we are very prone to develop vitamin D deficiency. So it is very common, and the ideal dosage is 60,000 international units weekly for 8 weeks. And then 60,000 international units monthly once for 1 year or 2 years, depending upon the level of the vitamin D3. So the more than that, the physical activity is very important, and then calcium-rich diets and sources of vitamin D, like dietary supplements, are very essential to prevent that. So, and also especially in post-menopausal individuals, they have severe osteoporosis, and the vitamin D3 is usually going to be less, and this patient has to be treated. They say that in the start before the menopause, that is perimenopausal itself, you have to start the drug. Otherwise, the first 2 years, that's the 1 year before menopause, and after 1 year, the maximum amount of bone mineral density is getting reduced at that level. If you start this vitamin D3 and calcium after 2 years, it's not already the bone mineral has been reduced. So that's the ideal period which you have to start perimenopausal itself. Calcium and vitamin D3 has to be supplemented. This is the ideal dosage, and though in maintenance we used to give 1,000 international units is sufficient per day for any of the patients, any of them.
I think it is relevant to ask Dr. Shanmuganathan now at this juncture about the preparation which he is going to prepare or prescribe for osteoporosis patient, especially the calcium. We have a variety of calcium medicines available in the oral form: calcium citrate maleate, calcium oxalate. So many brands are available, and there are a lot of apprehension in the patient's mind also. When you prescribe a calcium, immediately they will come and ask you, sir, will you produce a calcium stone in my kidney? This is a very common question which we come across, especially from our diabetic patients, when they are prescribing calcium for a longer time. What is your choice of calcium, sir?
The daily calcium needed in females below the age of 50 is around 1,000 milligrams per day. Above the age of 50, they need 1,200 milligrams per day. In males below the age of 70, 1,000 milligrams per day, and after the age of 70, 1,200 milligrams per day. That's an average dose requirement for the calcium. We have calcium carbonate, is the commonly used drug, and then we have calcium citrate, and we have calcium orotrate, calcium aspartate. All these brands are available in the market, and the absorption rate, if you see that the calcium citrate has a better absorption, and which should be taken without before food, whereas the other calciums can be taken after food. And for the absorption, we need the vitamin D3 and phosphorus is needed for the absorption. And regarding the
type of calcium which you are going to prescribe?
Calcium carbonate or calcium citrate, anything can be done. Anything that the adequate dosage is essential, and absorption before food or after food, like that it has to be thing. And other drugs like aspirin and other cardiological PPAs, all these affect the absorption of the calcium. All the things to be taken into account and to be taken. And especially now we have the vitamin K27, which is a molecule. We all know that vitamin K is essential for the clotting mechanism. This vitamin K2 is very essential for the conversion of osteocalcin, which is in the unhydroxylated form, which has to be converted into oxylated form by vitamin K. So vitamin K27 is very useful for the absorption, and also it prevents calcification in the kidneys and in the vessels. So arterial calcification is very high in the other calcium preparation. When you add vitamin K27, it lessens because of the various mechanisms by the osteocalcin mechanism. It prevents it. So vitamin K27 is a better calcium which we supplemented with vitamin K27. So that's the ideal one for giving.
Many a time a diabetologist is asked to control the blood sugar, especially when the patient is getting referred from an ophthalmologist because he wants to take a cataract surgery. Sometimes the person is supposed to go to a surgeon and their tooth has to be picked up. In these situations, we have to control the blood sugar and then only we refer them. Similarly, as Dr. Shanmuganathan was mentioning, intra-articular steroids also will definitely increase the blood sugar. In this situation, the role of a diabetologist is very important, and we have to reduce the blood sugar, and especially after the intra-articular injection of steroids, the blood level of sugar is going to mount up. Sometimes we switch over from oral glycemic, hyperglycemic agents to insulin, and in that way we are able to control the blood sugar. There are, of course, few more questions. For want of time, I am just skipping them. And if at all, if there are any questions from the floor, maybe we will take up 2 or 3 so that we will be able to do justice to the audience also. Any questions from the floor regarding the subjects which we have discussed? I am able to see a lot of children and women folk here. The time is already 10 and maybe beyond 10. So, one more question. Yes, sir. Sir, can you give a mic to him, sir? There is a question.
Which is best proton pump?
Sir, switch on the mic. I'm not able to hear.
Which is best proton pump inhibitor?
There is nothing like there is one proton pump inhibitor which is better than all the other. There are different aspects. There are minor differences in proton pump inhibitor usage. The rabeprazole has a shorter duration of action. That is one thing that is different from other proton pump inhibitors. So it is beneficial in certain ways and it is not beneficial in certain ways. So if you want to reduce the side effects, you can use the PPI with a shorter duration of action. When you want to have a complete acid suppression, you will use a once daily PPI which is having a 24 hours duration of action. And efficacy wise, compared to the first PPIs like omeprazole or lansoprazole, the newer PPIs have efficacy-wise are superior, but also they produce more complete acid suppression, leading on to certain side effects. So there is nothing like one PPI is superior to one PPI is superior in all the aspects. There are differences in different PPI, and there are interactions also, drug interactions also. Pantoprazole and rabeprazole are having lesser drug interactions with cardiac drugs compared to the other proton pump inhibitors. And regarding in pregnancy, pantoprazole have category B and others are not yet completely categorized or in category C. So these are some differences among PPA. So accordingly we can choose. There is nothing called one better PPA.
To add what
many longer use of PPA, it can cause CS stomach.
Yes, sir. Achlorhydria is one of the risk factors for gastric carcinoma. So initially when prazoles were introduced way back in 1980s, there was actually a fear in the minds of gastroenterologists and physicians about these proton pump inhibitors. These proton pump inhibitors completely knock the parietal cells, so it produces achlorhydria. But the nature is now trying to help us because new proton pumps are produced in the gastric mucosa. So even if you give proton pump inhibitor, the acid suppression may not be 100%. I think Dr. Arun will vouch on that. Would you like to add anything? Yes. So 100% achlorhydria is not possible. And there was also an apprehension that most of the prazoles will produce severe bacterial infection of the intestine. Sometimes it can even produce typhoid, all gram-negative bacteria can thrive. These complications is also not much seen, and that is the reason why we have started prescribing prazoles left and right.
Absolutely, sir. So the overall incidence of carcinoma stomach has not increased with PPI use. That is one thing that we have seen over the period of time. Especially in immunosuppressed individuals like in cirrhotics or patients with chronic kidney disease, the incidence of infections are high. Like in patients with cirrhosis, the incidence of spontaneous bacterial peritonitis is higher in patients who are on proton pump inhibitors compared to people who are not using proton pump inhibitors. So there are certain situations in which the infection rate is higher when proton pump inhibitors are used. And also, as we have already discussed, the incidence of pneumonia is slightly higher when we use a proton pump inhibitor for various reasons. But the issue of carcinoma stomach, we don't find a higher incidence of carcinoma stomach with proton pump inhibitor use.
And about your question, sir, most of the proton pump, especially the first generation like omeprazole and pantoprazole, they need a microacidic environment for them to act. The drug has to be absorbed, for which you need a small amount of acid. That's the reason why it has been insisted that the prazoles should not be combined with H2 receptor blockers or antacids. Many a time we prescribe H2 receptor rather than diazid gel or something like that. No, it should not be combined. But the later generation PPIs like the rabiprazole and all, they get absorbed even when the person's stomach is full. With majority of the time, the first generation prazoles were given in an empty stomach, but nowadays that particular thing is not mandatory. That is another difference between the prazoles. I think we have answered your question.
Okay, thanks.
And if there are no more questions, let me thank all the participants first for their patient listening in spite of your busy schedule and you have been keeping ourselves busy in this particular forum. And I thank my co-panelists for giving them their idea about the various questions. Once again, I thank the company, pharmaceutical company Kedida, for having given me this opportunity to be here and to update our knowledge in many of the chronic diseases. Instead of giving a didactic lecture, inviting 2 or 3 people for hours together, these type of forums will keep everyone abreast. Not only that, everyone awake. Nobody is nodding. And thank you very much for the opportunity. Thank you, sir.
Thank you so much, Dr. Govindrajan. Thank you so much. What a moderation. Let us give a big round of applause for this great moderation.